Learning Collaborative. I'm Erin Ficker. I'm excited to have you here. As you enter the room, please take a minute to answer our poll questions and our chat question, as you'll see on the far left side of your screen. What do you hope to get out of our webinar today? And our poll questions. Thanks so much. We will get started right at the top of the hour. Hi everyone again, and welcome to our webinar today, Highlights of the Child Safety Learning Collaborative. As you enter the room, we so appreciate you being early and on time. Please take a minute to answer our polls right in front there, and take a minute to answer the chat question that's to the far left of the screen. You'll see there's a chat, and you can type right into the box at the bottom of the screen there and answer the question, what do you hope to get out of today's webinar? I appreciate you taking just a minute to do that. And as we wait for folks to join us, we will start right at the top of the hour. So take just a minute to tell us a little bit about, have you been part of a learning collaborative or a COIN in the past? And what's your experience with quality improvement? Thanks so much, everyone, for taking time to take the polls. It looks like we have some folks who have already taken the time to answer, and I see that we have someone in our chat already who's ready to learn about new or existing programs, and hopefully we'll be able to tell you a little bit about that today. Have you been part of a learning collaborative? We see that we have people who have, or about half people who have, and half who are wanting to learn more, so that's exciting. We do have people who have are still learning about QI and its principles and processes, about half of us, so that's great too. And people who want to learn more about learning collaborative. So we'll definitely share that with you today. We're so excited to have you with us. We will get started right at the top of the hour. Again, my name is Erin. And as you come into the room, please take some time to answer our questions, our chat question and our poll questions. We'd love to hear a little bit about you before we get going. We will start, like I said, right at the top of the hour. That's looking for more information. Hopefully we'll be full of information for you today, and to learn more. Hopefully we'll be able to provide that for you today. I think we have lots to share. We continue to have people who are here to learn about QI, still a lot to learn. And folks who have been part of a learning collaborative or who are wanting to learn more. So great, it's really helpful for us to learn more about you. So we have just a few more minutes before we get started, so waiting for more of our colleagues and peers to join us on the webinar this morning. Not morning, it's afternoon in most places. So thank you for taking the time to join us this afternoon. Okay, thanks so much, everyone. We have people joining us now. My name is Erin, and I want to welcome you all to the highlights of the Child Safety Learning Collaborative webinar. Thank you so much for taking the time to be with us today. As you join, please feel free to answer our poll questions and our chat question. Our chat question, what do you hope to get out of today's webinar? So please, helpful if you share a little bit of that with us. We will get started in just 1 minute, 2 minutes, 1.5 maybe. Take some time to also fill out the polls at the bottom of the screen there to tell us a little bit about yourself, about your experience with learning collaboratives and your experience with quality improvement. So it looks like we have a split between people who try to use QI principles at work and those people who are still learning about QI principles and processes, which is wonderful. And also a split between people who've been a part of a learning collaborative and those who are really wanting to learn more. So we're excited to have you here today to learn more about that. We have multiple people who are typing and joining us. Thank you so much. We're just going to get started in just 1 minute. Thank you all for being here on time and ready to go. People wanting to learn more about QI. Always enjoy learning new info. So thank you for being here. Wonderful. Great. Well, it is the top of the hour. So thank you so much for as you joined us for taking a minute to complete our polls. We are going to go ahead and get started. So welcome again to Highlights of Child Safety Learning Collaborative. My name is Erin Ficker, and I will be with you today. So let's go ahead and get started. The Child Safety Network is funded by the U.S. Department of Health and Human Services, HRSA, the Child and Adolescent Injury and Violence Division. None of what is the information or content and conclusions of those are of the author and should not be construed as the official position or policy, nor should be endorsement of HRSA, HHS, or the U.S. government. Just some technical tips. I know a lot of us have been on a lot of webinars these days, but just a few key tips. We ask that you use the question and answer to the left of the screen at any time to ask questions. This session is being recorded, so will be available on our website in the future. If you experience any audio issues, you can dial in and mute your computer speakers. You also can see that number is at the top of the screen in the audio info pod. And you are muted for this session, so please do use that Q&A pod to communicate with us. And again, my name is Erin Ficker. I work with the Children's Safety Network as one of our Child Safety Network, or excuse me, as one of our Child Safety Learning Collaborative, or CSLC, co-managers, and I serve as the topic lead for the Sudden Unexpected Infant Death Prevention topic team. And I'm joined today by Jim Vetter. Jim is also one of our co-managers. He's an expert in social emotional learning and is the lead for our bullying prevention topic team. And we are delighted to have Jim joining us as our facilitator today. In addition to Jim and I, we also have with us 3 CSLC state team representatives. These are wonderful folks who just agreed to share their stories with us today. We have Melissa Ellis from Iowa, Dina Liska from Wisconsin, and Brittany Willis from Tennessee, who will be sharing their stories about their involvement with the CSLC. So today's agenda, we will be going through an overview briefly of the Children's Safety Network. We will be talking a little bit about the Child Safety Learning Collaborative. We will be going over And then we'll be just really getting into the meat of the matter, which is to hear from Iowa, Wisconsin, and Tennessee about their work in bullying prevention, motor vehicle traffic safety, and suicide and self-harm prevention. And then we'll leave some time at the end for questions. So please, as we go along, if you have questions, take the time to add those into the Q&A. It'd be helpful, and we will answer them as we go along if we're able, or we'll save them to the end for that question and answer. Great. So the Children's Safety Network, our goal is to equip states and jurisdictions to reduce serious and fatal injuries among children, infants, and youth. We do this by addressing injury-related performance measures, applying the public health approach, strengthening states' capacities, their capacity for injury and violence prevention programs, and using data-driven decisions to accelerate their prevention efforts and helping them to implement effective strategies and evidence-based programs. The Children's Safety Network has a framework for quality improvement that we use to drive our work. We accomplish our goals through this framework. The framework has its three main components that you'll see of child safety expertise, leadership and management, systems improvement. And it's through these three components that we use to increase workforce, to build workforce development, to develop the child safety workforce, and to improve injury and violence prevention systems. And through those two outputs, it is that we help to create positive health impacts. So we really are creating greater knowledge in the field, creating the application, increasing the application of quality improvement, and then really reducing injury and violence outcomes. The three main components that I touched on, child safety expertise, we really focus on these three. So strong child safety expertise means evidence-based and evidence-informed strategies and programs. We focus on building capacity and understanding of those types of programs, and also providing technical assistance from child safety experts. Management and leadership, working with senior leadership to support and build their expertise, and managers who lead. And systems improvement is really the work we do around quality improvement approaches, implementation science, and helping people develop systems thinking. One of the ways that we use this framework and one of the ways that we accomplish our goals is through the work of the Child Safety Learning Collaborative, or as we lovingly call it, the CSLC. The CSLC brings states and jurisdictions together to work as teams with shared aims, using and learning quality improvement methods, implementing and spreading evidence-based strategies through a peer learning approach, collaborating across teams, across states, and listing through targeted technical assistance. We do this all through a very intentional peer learning approach. We focus on the organizational level change in a collaborative learning environment, or a collaborative environment across the states. The Quality Improvement Learning Collaborative, the Learning Collaborative focuses on quality improvement to identify areas that are ready for improvement, to develop a system to support innovation and sustainability, to use data. So we really focus on helping people use data to inform those decisions, and to implement and spread evidence-based strategies and programs. The work we do focuses around building tools and supporting states to increase their use of quality improvement. The CSLC began in December of 2019. Our first cohort ran 18 months through April of 2020. We are just now launching our second cohort, which will run through October of 2021. And then cohort 3 will begin in April, will begin and run another 18 months through April 2023. So each 18-month cohort, each cohort is 18 months, and we're just starting our second one. So we're excited to be in really the middle of this project and with these teams. We have over 20 states who are participating in cohorts 1 and or cohort 2 from across the country. And as we launch into the second cohort, invite new teams in and see teams take their learnings and move on. As we launch this cohort, we are so proud of some of the progress that we have already seen across these teams. We've seen an increase in the number of parents and caregivers receiving safe sleep education in schools, increasing their use of evidence-based programs, training, and certifying child safety seat technicians. We've seen an increase in schools providing teen driver safety programs and schools providing gatekeeper training. It truly is an amazing amount of work that these states and teams have put in. But you don't really want to hear that from me. What you really want to hear from is the states who are doing this work. So I want to turn it over to Jim Vetter to introduce our states who will be sharing with you their stories.
Great, thanks, Erin. And we are really excited about the teams that we have ready to share with you today. We've been doing just some really wonderful work and using these different aspects of the child safety framework to help produce positive results for children and adolescents in their own states. So the first person I'd love to introduce is Melissa Ellis, who is here with Iowa's bullying prevention team. That Melissa's been with the Iowa Department of Health for 14 years. Melissa predominantly works within the state's Title V program, implementing and monitoring several statewide initiatives, and most recently, the bullying prevention efforts in the state related to the Title V program's National Performance Measure number 9. So welcome, Melissa.
Hi, Jim. Thank you so much for having me today and inviting me to share some thoughts about our experience in the Child Safety Learning Collaborative, and so I really appreciate this opportunity. I'd like to walk you through today the structure of our project and how we really engaged with the Child Safety Learning Collaborative to move our work along and keep quality improvement at the forefront of our work. Beginning, we started looking at the change package, as you can see here. It was the HRSA Maternal and Child Health Assessing Prevention Capacity and Implementing Change package that we used from the very beginning of our project to really assess where we were in looking at bullying prevention here in Iowa. From this, using the change package, we really could set a clear aim statement and really look at what we wanted to look at was reducing the bullying victimization of those youth who encountered bullying most likely due to their sexual orientation or gender identity. So you can see what our aim statement was here, and then we we got to really dig deep and look at what our aim statement was at the very beginning of the project. And again, just as a reminder, participating in the Learning Collaborative, we had a team leader who ironically was Jim, who introduced me. Jim was with us the entire time through the project. So we were very fortunate to have a team leader who was there to encourage us, to move our work along, because as we all know, sometimes when we have so many hats that we wear at our jobs, it's hard to lose sight of several initiatives if one seems more important than the other at the time. And so really, it was nice to have Jim or any of the team leaders there with us. And so the second part of our project was really looking at, due to our aim statement and what we wanted to accomplish in our aim statement, we really went to work brainstorming who our stakeholders were, and then soon those stakeholders soon became our partner in the project. We partnered with, our state Title V program partnered with Iowa Safe Schools. And over in the yellow box here, you can see Iowa Safe Schools is a group that provides comprehensive support, victim services, many resources, and organizes statewide events for the LGBTQ and allied youth here in Iowa. And they serve so many kids here in Iowa. And so we thought that they would be a good fit after brainstorming about who our partners could be and then actually engaging them in our project. We entered into a service agreement with Iowa Safe Schools. The first priority we had with Iowa Safe Schools was asking them to facilitate focus groups for us, really meet with those teenagers, those adolescents that they see on a daily basis, monthly basis, and really get feedback from them and try to gauge where they were in looking at bullying prevention here in Iowa, what was important to them, what they felt they needed support in when it came down to bullying prevention. The second priority that we engaged our partner with was a pilot project. They held a pilot project for a week-long camp in the summer and facilitated a pilot project for us using a curriculum, and I'll talk about that curriculum here in a little bit, using a curriculum that the Learning Collaborative helped us select, as well as our partners helped us select to implement. And from that, the service agreement, we did engage them in collecting data, and then finally wrapping up our pilot project and some of the other projects that they did for us. They could establish and help us learn what plans we had for the future. So in choosing our curriculum, and again, I'll talk about that here later, but in choosing our curriculum, we looked at what did we really want to accomplish. And my favorite part of the project was really learning from the collaborative, learning from Jim, and asking them, what we could find that best suited our project and what we wanted to do. And we really felt that incorporating youth voice into our project was probably one of the most important aspects of choosing a curriculum and implementing the curriculum. So we felt that that was very important and had great support from the collaborative in getting input from youth and even having youth leaders provide us feedback on our programming. So after we did our pilot project, we ran some focus groups, did a pilot project. Our partner, Iowa Safe Schools, implemented several of the curriculums in several GSAs across the state. And through that, we really learned, the Learning Collaborative helped us find evidence-based programming through our request for technical assistance. We were at a position where we wanted to select programming to provide, and so we put in a technical assistance request to the collaborative. They were very responsive, and the collaborative and our team leader was able to provide us with many options for programming. We had the opportunity to sit with our partners and walk through the options presented to us and make a selection. And from that, picking a curriculum that was sustainable, that was evidence-based, and was sustainable was very important to us. And in the end, we did agree that the evidence-based bullying prevention program could be integrated into future school-based GSA programming and is really sustainable with little financial resources. And as we all know, especially in Title V work, things ebb and flow and shifts in priorities are made. In our most recent Iowa statewide Title V needs assessment, some of our priorities and measures did shift. So knowing that we had chosen a bullying prevention program that was sustainable beyond this project was very important to us. And finally, as I wrap up, I want to highlight the value of Iowa's participation in the Child Safety Learning Collaborative and on the bullying prevention team. So what's the value in Iowa's participation in the Child Safety Learning Collaborative? First off, we had unlimited resources to guide our work, all while keeping us focused on quality improvement as we advanced our work. We used the Bullying Prevention Change Package. We used coalition building tools that could help us identify who our stakeholders were, who our potential partners could be, and even caught ourselves doing some PDSA work without us even realizing it. And having Jim there to encourage us to seek technical assistance when we needed it. And they all had a phenomenal response to any of the questions we had or assistance that we needed. We had unlimited encouragement to seek out and advance evidence-based strategies, all while engaging our partners and a youth voice in the process. And finally, we had critical skills learned from our engagement with the collaborative that we can carry forward in other projects as we move on. We have a continued partnership development, and then for myself specifically, workforce development skills for strategic planning, systems building, and implementing evidence-based policies, evidence-based strategies, and the importance of measuring change over time is very important to me in my work that I do for the state of Iowa. And overall, from the beginning slide, one of the beginning slides that Erin had shared, we really felt that our final end goal was that output of creating positive health impacts for those adolescents that we served. And so I think we can stop, and I'd be glad to take any questions.
Yeah, thank you so much, Melissa. And just wonderful, the kinds of work that you've been able to do to promote those kind of positive outcomes in Iowa. I've got some questions. I know that someone had a question about the cohorts, and we will definitely address that before the end. And as folks have any questions about what Melissa has shared, you can just go over at any time during any of the presentations, and just in the bottom left-hand side of your screen, there's that little Q&A area. Feel free to type your questions in there. But I'm interested, Melissa, that in the kind of process that you went through, this kind of systems improvement process, I'm wondering, it's not uncommon, like back in my work at Virginia Department of Health and other folks, that to just, you get some funding or you get some support and just roll a program out because you feel like that's the way to get something out there quickly and do some good. But I noticed that in your process, you went through a whole kind of piloting process first. And I'm wondering, why did you do that, and what did you find valuable about going through the piloting?
Sure, thanks for that question. we felt that it was important to pilot the curriculum that we had chosen on a very small scale. It was a curriculum that was evidence-based. It was presented to us as an option from the Learning Collaborative, and so we felt that maybe starting at a smaller scale, we could really look at the impact that the curriculum had on its participants. And even from that pilot, we learned a lot from the youth. They really had a chance to provide some feedback, and so really they could talk to us about, any nuances that we felt that were in the curriculum, and as well as the most important part was that we could make adjustments. So moving forward and implementing in further GSAs or with further participants, we could make those adjustments and really feel like we were successful in the project.
That's great. So after having that summer camp where you did the piloting, then by the fall you were ready to really kind of roll it out. That's really wonderful. And it sounds like you built a strong partnership there with Iowa Safe Schools and used an evidence-informed strategy to do it. So just wonderful, and thank you so much for sharing, Melissa.
Well, thank you for inviting me again today.
Of course. Next, we'd like to hear about Wisconsin's Motor Vehicle Traffic Safety Team. And presenting about that is Dina Liska. Dina is an injury prevention program manager for Children's Hospital of Wisconsin. Doing that, Dina coordinates the Crossroads Teen Driving Safety Program through partnerships with Wisconsin Department of Transportation, Department of Health, and State Farm. And we'll hear more about those partnerships in a minute. Dina began her career in injury prevention as a firefighter and emergency medical technician. And Dina has been a certified child passenger safety technician and instructor for more than 10 years. Dina, welcome.
Hi, thank you. Okay, so I wanted to talk a little bit about Wisconsin's experience with the Child Safety Learning Collaborative. We are coming into, where we came into this cohort 2 as a former participant of cohort 1, and also we had worked with the Child Safety Collaborative Innovation and Improvement Network, or the Child Safety COIN, for 2 cohorts as well. So we had come in with a little bit of background in QI and some of the processes already, but I want to speak to one of the programs that we did specifically during cohort 1 of the CSLC. So we implemented a program that was a partnership to reduce teen driver distraction. The project goals were to address the risks related to reckless and distracted driving in Wisconsin, specifically among teens, and then to increase the collaboration between state partners, to increase the number of trainers that we had in the state, and to increase the number of youth who participate in the program. So we used the evidence-based program, What Do You Consider Lethal?, to engage and educate and empower teens to prevent car crashes. The program focuses on areas of peer passengers, nighttime driving, reckless and distracted driving, and also has graduated driver licensing components. So the process is that we worked with several agencies that we had partnerships with, that we had developed partnerships with over the years. So this was a true cross-sector pilot. We worked with fire and EMS professionals. We identified those through our partner agency, Emergency Medical Services for Children. Children's Wisconsin conducted train-the-trainer sessions across the state. We did a lot of driving during that time. And then we provided the materials at no cost to the agency, and we were also able to provide them with a stipend to offset some of their time. And then after the training, the agencies engaged with schools, driver education programs, and community groups within their community to implement training to the youth. Additionally, the Department of Health Services provided funding for the materials and the stipends through the Wisconsin Violence and Injury Prevention Program. So WeVIP, or SVIP, for those of you who are familiar with that program. And then our Department of Transportation funded the travel expenses to deliver the trainings to the providers. And then both agencies provided support to us as regular partners, as ongoing partners, but then also by connecting us to additional organizations and individuals who could help us to further the program. So the results of the program, from September to December of 2019, Children's Wisconsin conducted 9 classes. We trained 56 professionals from 40 different agencies in 16 out of 72 counties. And at the end of the pilot, 7 sessions were delivered, reaching about 125 teens, and 4 additional communities were working with schools to schedule programs. We also had some anecdotal evidence of success that we were happy to hear about. In 2 of the communities, the teen went back to their parent or caregiver and discussed the content, and then the parent or caregiver went to the EMS provider who had delivered the program and accurately relayed the information that was given to the student back to them. So not just firsthand, but secondhand, it came back correctly. So that was encouraging to us. This was also in one of our communities. This was the way that the fire department's community paramedics were invited in to do education on additional topic areas as well. So it led to ongoing education opportunities for them. So we participated, like I said, in prior QI, quality improvement activities. And through those activities with CSN and the COIN and the CSLC, a lot of acronyms, we were able to develop a really good set of quality improvement skills. So we used stakeholder analysis, we used phases of improvement, we used plan, do, study, act cycles, and we've used spread planning. And I'm sure there's other things that we've used as well. But the one thing I would like to really highlight that was the starting point for us is what you're seeing on the right-hand side of your screen is our theory of change. And that was organized based around the change package that was one of the very first tools that we were given in this process. And the color coding is important because it uses the socio-ecological model with the teen in the middle and then those broadening areas of influence as you get out to the blue. So our approach has stakeholder, community, and interpersonal elements to it. And like I said, the key to this is that we had a clear theory of change. It was organized around the change package, organized around the socio-ecological model. We were able to leverage working relationships that we had been building for many years because we were very clear on who our stakeholders were. And then we also had a very strong understanding of what evidence-based programs and practices were and what they looked like in this topic area. So the time from opportunity to completion of the project was about 6 months. So our next steps, we are looking at how we adjust this to the virtual world that we are in currently, how we might still be able to deliver some socially distanced versions of this, and how to continue to engage with our EMS providers and the schools and the teams that we had been working with before. So it's a constant process of going back to those QI tools and going back to the things that we were able to draw from our participation in this cohort. So excellent things for us to have at our disposal as we try to navigate the future coming up. So,
that's
thank
great.
you.
Well, that certainly positions you well to flex in this uncertain time. So Dina, one more question I have for you, that you were able in this initiative to pull together a major hospital, the 2 state agencies and the emergency medical services, that can be a tricky feat. How did you bring those partners together around this? How did that start? How did that work?
When we looked at the change package, we had the evidence and the clear alignment of the drivers, primary and secondary drivers, and things that would influence our success. And so we were able to go to those partners and talk very clearly about what needed to happen and about what we had the resources for and what we didn't, so that when those resources came around, everyone knew what was on our wish list.
Mm-hmm, mm-hmm, mm-hmm. And did you already have relationships built with those folks as well?
We did. We've worked for a long time with our Department of Transportation and our Department of Health Services.
Uh-huh. So you're then able to leverage those existing relationships, and you had this clear theory of change, so each partner was able to see how they connected into the bigger picture?
That's exactly how it worked. It's just having that theory of change made it so easy and so clear to communicate with our partners and to really have a conversation about what the next steps would look like.
Well, that's fantastic. Dina, thank you so much.
Thank you.
Next, we'd like to hear from Tennessee Suicide and Self-Harm Prevention Team. With the Tennessee team represented today by Brittany Willis, Brittany is the Suicide Prevention Program Director for Tennessee Department of Health, where she works closely with various stakeholders across the state to identify gaps in mental health and suicide prevention services, helping to determine what support is still needed within local Tennessee communities for those at risk for suicide. Brittany conducts weekly surveillance for suicide attempts, suicidal ideation, and intentional self-harm in children 18 years of age and younger using the Essence database, which we'll hear about in a moment. Brittany, welcome.
Hey, Jim. Thanks so much for that. So I just wanted to say thank you for giving me the opportunity to speak today. We're really lucky in Tennessee where we really work very well together already. We have several collaborative partnerships, but being able to join the Child Safety Learning Collaborative team really let us work together and hone in on a specific issue in Tennessee, and that's youth suicide. So suicide is the second leading cause of death for children 10 to 17 in Tennessee, and we really wanted to identify ways where, as you can see, the highest rates for both self-harm injury and suicidal ideation in Tennessee were between of children between the ages of 15 and 24. And so we really wanted to work together, myself at the Tennessee Department of Health, and then with partnerships with Tennessee Department of Mental Health and Substance Abuse Services and Tennessee Department of Education, as well as the Prevention Alliance of Tennessee and the TriStar Health Hospitals to figure out how we can work together to reduce suicide-related behavior in Tennessee. So we looked over all of the strategies and decided that we wanted to spread evidence-based gatekeeper training to youth impactors across the state. We are really fortunate in Tennessee that we have the Tennessee Suicide Prevention Network. And so we already have a collaborative partnership with the Tennessee Suicide Prevention Network that has the capacity to really spread these QPR trainings. So for those of you who do not know what QPR, I just wanted to give a brief introduction, and it's just a way, it's designed to teach participants how to recognize the warning signs of suicide and question someone about whether or not they're having thoughts of suicide, and then how to refer them to help. And so with our work with the CSLC, we really wanted to first look at our data and be data informed. And so at the beginning of cohort 1 with the CSLC, we really just looked at the training data with TSPN, which is the Tennessee Suicide Prevention Network. And we knew that we wanted to increase the number of youth impactors trained to utilize QPR. And originally, when we started our work with the CSLC, we defined youth impactor as any person within a community who worked in a school setting. And I'd say that's been our biggest accomplishment with working with the CSLC is working with Maria and being able to kind of understand that we can create our own definitions of youth impactor and who we reach. And so after looking at that and looking at quality improvement and working through several Plan, Do, Study, Act, so our PDSAs, and looking at our data again, we realized that we needed to redefine our definition of youth impactor, because by strictly focusing on those who worked in schools, we weren't reaching everyone that we could as far as youth impactors go. So we set a new goal of trying to increase the number of youth impactors trained to utilize QPR from 2,846 youth impactors in 2018 to a goal of 3,000 youth impactors trained in 2019. And we continuously did Plan, Do, Study Acts every 90 days through our work with the collaborative and our topic calls and being able to engage with our leadership at the CSLC and being able to just hear what other states were doing really helped us hone in on who we needed to target for these trainings and how we really needed to spread these trainings. So in 2019, we're happy to report that we provided 111 QPR gatekeeper trainings across the state and far surpassed our goal of 3,000 and actually trained 3,737 youth impactors across the state in 2019. And from redefining that youth impactor definition, we were able to reach youth group leaders, evidence-based home visitors, home educators, bus drivers, boys and girls club staff. And so through our work with the CSLC, we really were able to reach more people within the community across our state and hopefully reduce the amount of children who suffer from suicide-related behavior. So some of our successes through our work with the CSLC was setting that clear definition for youth impactor, because it really influenced the way we viewed our chosen strategy with the collaborative, and it helped us determine a more accurate goal when considering who to offer these trainings to. And then again, one of our challenges in the beginning was getting a clear definition. We found out that we really limited ourselves in the beginning, and through our work with the collaborative, we were able to really expand our work by working through some of those quality improvement strategies. This is just an example of our current 90-day aim statement and how our work through the collaborative has really influenced the way that we look at things at the Department of Health and how we view things as a collaborative team in Tennessee. So as Jim mentioned, we do surveillance with essence monitoring, and so we've really been able to work with the collaborative team and look at data available in near real time to be able to target our QPR trainings to our highest risk areas. And so for those of you who do not know, Essence is actually a syndromic surveillance system used. It's primarily used for infectious disease, but we've been able to pull data for suicide-related behavior using discharge diagnosis codes. And so I'm doing weekly surveillance. About 80% of hospitals within Tennessee that can report into Essence currently do. And so I'm using data currently pulled weekly, and we're doing weekly monitoring for suicide attempts, suicidal ideation, and intentional self-harm visits. So these are emergency department visits in children 18 years of age and under. So by using this data, we have created a rapid prevention response plan, and this helps indicate areas within the state showing increased levels of suicide-related behavior in children and youth. And through this plan, we work with our collaborative team to be able to identify areas within the state that are seeing current increases in suicide-related behavior and really spread those QPR trainings in near real time to the areas within the state that are seeing current increases in suicide-related behavior in children and youth. And through our work with the collaborative, we're really able to hone in on who could we potentially target within these areas that do have interactions with children and youth across our state. And I will say in the last 2 months, with everything that has happened with the COVID-19 pandemic, having our collaborative team and being able to use our quality improvement strategies that we've learned through the collaborative have really helped us kind of adapt and acclimate to this new normal that we're all under, and how can we target youth impactors from a home environment and who currently has interactions with children and youth across our state, because now they're not necessarily getting those interactions in schools or churches. And so who can we target now? And so we're really using our quality improvement currently in Tennessee that we've learned through the collaborative to really hone in on how we can continue this work, you know, in the middle of a pandemic. So some of our next steps currently is continue to work with new stakeholders, continue to do weekly monitoring. We're going to develop and distribute some additional needs assessment surveys in order to continue to review gaps in our states. And then we really hope to create a suicide prevention resource guide for our state. And then if anyone has any questions at all, please feel free to ask or contact me directly.
So Dina, that's really interesting. So we were talking about using that Essence system to be able to target more clearly where this kind of training is most needed. That, as you're saying, allows you to be flexible. So now in this COVID-19 time, if different areas of the state have higher areas of need, it sounds like then you can respond more effectively to those areas. Is that right?
Yeah, that's exactly right. And so we actually look at this from a county level. Tennessee has 95 counties. And TSPN, the Tennessee Suicide Prevention Network, actually has 9 regional directors that cover each county in our state. So we can work directly with our coordinated school health coordinators and our TSPN regional directors to really spread these QPR trainings in the areas that are seeing live increases of suicide-related behavior. And so we're monitoring within the last week for Essence monitoring. So I just did monitoring yesterday, for instance, on the week of May 10th through May 16th. And so it's a little bit behind, but it really shows us which areas of the state are seeing current increases in behavior, and we're able to spread that pretty rapidly.
And interesting. And I'm curious that the strategy that you chose with QPR, that you really had a focus around increasing child safety expertise among your key stakeholders, in this case, your youth impactors. And I'm wondering, because again, different initiatives choose different strategies, that you could have done social media posts instead about suicide prevention. Why do you think it was particularly helpful to increase that child safety expertise of those key stakeholders, of those youth impactors?
Well, specifically for suicide, a huge part of suicide prevention and being able to prevent suicide and the rates of suicide is being able to identify, assist, and support those at risk. And so, we want it to be able to spread the knowledge needed for those within our communities to know how to identify a child who may be at risk, to describe warning signs and risk factors, and really equip our youth impactors across the state to be able to feel comfortable to reach out to children who they feel may be at risk and ask those questions and be there to support them and help them get the help that they need to go on to live healthy, productive lives. So by increasing the child safety expertise in the communities and in the targeted way you did, you're able to reach people, it sounds like, young people who a campaign just coming out of the state agency might not reach. And you have folks who are kind of trusted in the community who can carry out that information or that change with folks. That's really important. So I'm seeing Nancy Granger asks, could you please repeat what particular suicide prevention program that was that you used? So Essence is actually a CDC database.
I think they're asking, I'm sorry, Dana, I think they're asking not as much about the data system as the training program that you used.
Oh, it's QPR, so Question, Persuade, Refer. And it is a program that is designed to teach participants how to recognize the warning signs of suicide, how to ask the question to someone of whether or not they are suicidal, and then it goes through steps of how to persuade someone to get help, and then how to refer that individual to help on a local level.
Great, thanks. So we've got some questions coming in now for any and all of our panelists, which is fantastic. So the question that's come in that Carol Kerr-Swinger has asked about whether any of you have done any work with your child fatality review teams, if your child has a child fatality review team. So any of you connected with child fatality review teams?
This is Brittany from Tennessee. We work very closely with our child fatality review team. I actually, in the section that I'm under at the Tennessee Department of Health, it's injury prevention and detection. And so
the meeting
for improvement from CFR teams across the state and how we can assist them. I often give my CFR state program director kind of like notes on where we are as a collaborative team. So yes, we work very closely.
And what do you say, what are some of the advantages you find of the benefits of working with the child fatality review team?
We can really understand what is happening and where our successes and challenges and where our barriers are at a local level. So, you know, at a state level, we see things from one lens. So being able to work with CFR, we can really see how things affect individuals at a local level and be able to adapt things to be able to help them at a local level rather than at a state level.
So that enables you to really understand sort of where in the state different issues are happening, to be able to then address those in a kind of focused way, and sounds like to understand more about what the needs are even. Is that right?
Yep.
Oh, that's great. So I'm wondering, Melissa, in the work that you were doing around bullying prevention, I'm wondering whether you looked at anything around cyberbullying. We have someone, a participant was asking about cyberbullying. That with the bullying that you were noticing in Iowa, was that all in person, or did you hear about online bullying as well?
Definitely, that was one of the points that we clearly heard from our youth that participated in focus groups, that those adolescents aren't bullying face-to-face any longer, and I don't think that's any surprise to anyone. But we heard that quite often in the GSAs and then also in our focus groups, that bullying was happening behind a keyboard or behind a cell phone and through those anonymous social media apps. So yes, we did hear about that quite often.
And I'm wondering, Melissa, have you happened to have heard anything about any increases that might be happening now during COVID-19 time, when it seems like everybody's online all the time?
You know, Jim, I really haven't. I haven't heard much of that right now, but that doesn't mean it's not happening.
Yeah. Well, I think in some ways it may be hard for us to be monitoring right now because we're not in contact with those who are providing services to youth in the same way as we might have been. But,
exactly, and just to add to that, you know, our interaction with schools and their teachers and those guidance counselors as well, losing that one-on-one contact is very concerning to us as well.
And I would imagine, thanks Melissa, I imagine that might be concern around suicide prevention as well, that not being able to have that kind of you know, having those youth impactors not being in touch with the youth as much as they might have been. Were you finding concerns around that as well in Tennessee?
Oh yes, absolutely. So like I said, that's how we're kind of trying to see who is still having contact with youth and children across the state, because it's different now. And what we're finding really is that teachers, school year's wrapping up finally this year, but teachers, and especially like our coordinated school health coordinators, are working closely with the school counselors, and so they already know what children are potentially at risk. And so what we're finding is actually people are keeping up with students a lot closer now. It's just through a virtual component. And so we've moved all of our QPR trainings to be able to be done virtually. And so we're actually being able to spread it more because people are at home. And so we're finding out that this actually isn't, we're not seeing any increases in suicide-related behavior, and those that work with youth are kind of on high alert, and so they're actually checking in with youth more than they were when they were seeing them every single day.
Oh, that's really interesting. So even though the shifts have made it difficult for some of the youth impactors to have contact in the way they normally would, typically would, that you've actually been able to increase your training and because of the situation. Well, that's very interesting. And I'm wondering, Dina, in terms of the motor vehicle traffic safety work, sort of motor vehicle use is certainly very different these days. That have you found that to be impacting the work that you do?
We have. From the basic standpoint that we're approaching things with the mindset that what we thought we knew, we might not know. So, for example, we used to know that peer passengers would exponentially increase the risk of a crash with a teen driver. But now with social distancing and parents regulating who their children are visiting with or interacting with, we may or may not see that to the degree as pre-COVID. So we're moving forward with what we thought we knew, but understanding that it might be different now than it was before. And we're also finding some of the similar experiences that where it was challenging to get 20 parents in a classroom to hear a presentation, we might be able to spend the same amount of energy and reach 20 parents virtually quite a bit easier. So.
Yep, that makes a lot of sense. So I'm curious that as each of you were talking about the projects that you do, the initiatives that you're involved with, that several of you mentioned the value of finding forums for peer sharing, to be able to chat both with folks who have expertise in the field, but also just to share information with your peers in other states. And I'm wondering, as you reflect on that, if any of you would like to say a little bit more about why have you found peer sharing to be valuable? And I will toss that out to any of you.
Well, this is Dina, and I think the peer sharing is because we're working on a common topic, and we're using quality improvement approaches together. So it saves us time if another community has already done some PDSA cycles and learned some things. We might be able to do a PDSA cycle in less time because we can start at a position of maybe making some assumptions based on what they've learned, and see if maybe there's things that that do apply to our community and that we can just move ahead with.
Mm-hmm. So being able to see other people going through that plan, do, study, act cycle, like Melissa's Iowa bullying prevention team did as they went through the kind of the piloting, that can be helpful. I wonder too whether anybody found, Melissa, you were mentioning the kind of the benefits of helping to, with so many different possible projects, so many projects that you're working on currently, of having a place to come that helped you focus on this project for a while. And I'm wondering if you could say a little bit more about that, if that was your experience.
Absolutely. Thanks for that question. As we all know, our lives are really busy, and I would almost expect everyone on this webinar today has more than one thing to do at the office, especially now. And so with the Learning Collaborative, it was really a time that we had set aside monthly or bi-monthly, that we could really go back and look at what our aim statement was, report in as to what we had accomplished through the month, what maybe our next steps were, what maybe we wanted to do next, and then maybe really just look at where we were and really kind of gave us encouragement to keep working. Because like I said, it is so hard to put things on the back burner when you have so many things to do in your programming at a state level or a county level or even local level. So it really gave us an opportunity to check in, and having that team leader and you being our team leader kept us moving and encouraging us to keep plugging away at that work, and we really did find that those check-ins were so important to us.
Well, thank you to all three of you. Really wonderful to hear everything that you've been able to share with us today. Erin, back over to you.
Thank you, Jim, so much, and thank you to all of our presenters for sharing so much of your work with us and with the audience here today. I wanted to let everyone know that coming very soon, we have a new CSN-A resource coming your way, a framework for quality improvement and innovation in child safety. And this is an implementation guide that really does highlight a lot of what we spoke to today and goes into much greater depth. It highlights the framework that we spoke of and highlights some of the stories that you heard today. So we will have that out at the end of this month. You'll actually receive it in an email as a follow-up to this webinar. And we are now going to send you out to an evaluation that will, we ask you to complete. We are always following best QI practices. So we ask to get some feedback from you on our webinar today. So thank you for being here. Thank you for taking a minute to complete our evaluation. And thank you to our presenters today so much. Thanks, everyone.